Okay, why don't we start over with you, Tayson?
All right. So, 15-year-old male, pain and popping after golf. So, that olecranon, there is that linear signal going through the olecranon process, but I think it's a growth plate, right?
Okay. I mean, we don't see much edema.
Yeah.
Yeah, and then a little prominence to the fold here. Anything else? What do you think's going on there?
I'm not sure.
So this is obviously fat, and it's not the usual fat signal. So this is a fat pad contusion that occurred.
Okay.
And you're right. This is not a fracture. This is a normal growth plate that's getting ready to fuse, but isn't fused yet in this patient. And this is a fat pad contusion.
Okay.
Okay. Uh, let's see. Looking anterior to the humerus, there's that low signal focus there. Not entirely sure what that is.
Right. See a little bit of an effusion.
Mhm.
Right. And this is just a loose body.
All right. Cool.
Okay, 38 MLB pitcher unable to straighten the arm. Um,
So I think we're ready to discuss it. Most Major League Baseball pitchers can't straighten their pitching arm.
mm, um, okay, looking at the posterior humerus, thinking the olecranon fossa, there's just bone irregularity.
Yeah, right in here.
Yeah, that looks chronic. And
We can see in a
yeah,
slightly different cut.
yeah, that looks like a
Expressed images.
loose body.
Right. So these are big osteophytes and loose bodies, and these can due to hypertrophic bone formation from chronic repetitive trauma, and occasionally they have to be resected. But as we talked about before, you have to be careful not to over resect it.
It looks like the patient has a flexor deformity.
What do you mean by flexor deformity, John?
Well, they cannot straighten out the elbow.
Oh, right. They can't straighten their elbow out. That's exactly right, due to the mass effect from the osteophytes here.
And that's the next picture, I would think. I don't think this fella can throw very well right now.
Well, he was throwing in the major league. I don't remember which team he's on, but he's a major league baseball pitcher, and he was active at this time, but having pain uh, in the elbow, and you can see there's
That's
some
old age.
Yeah, he's 38, which is very old for a pitcher, right? This is pretty close to the end of his career, right?
A lot of increasing where the organoid process is supposed to be. Is that
Okay.
fractured and displaced?
Yeah, and this is a fracture in a loose body. That's right. Yeah. And here you can see what was fractured is the radial head. This is the source of that loose
Okay.
body. Yeah. Okay. Well, already gave you the results. Go ahead. Why don't you tell us about this?
All right. So there's some edema in that anconeus muscle that I've been concerned about grade 1 strain.
Okay, well, let's go on and talk about nerves now. So, and around the elbow, we'll talk about the ulnar nerve, median nerve, and the radial nerve. And first, let's just kind of talk about nerves in general. So, the anatomy, you have individual axons where the pulse is transmitted. And around that, you have kind of a sheath like insulation and a wire, which is the myelin sheath. And then you have the endoneurium, These are the bundles of each of the axons, and then the axons are bundled together into really a nerve fascicle. And surrounding this bundle of nerves is the perineurium, which creates the fascicle. And external nerves are basically collections of multiple fascicles, which then innervate the distal tissues. And centrally, there's usually an artery and a vein, as we're seeing here. And then around the entire nerve is the epineurium, around the entire nerve. So a lot of people have looked at MR findings in nerve injury, and there's a lot of research going on right now in this area, especially using diffusion and diffuser tension imaging. I think a lot of that technology is still not widely available, but there are a number of academic centers which are really actively involved in this process. So there are a lot of things to look for to look at nerve abnormalities. You can look at the size of the nerve. So nerves tend to increase in size the higher the grade injury you go to until you start getting focal partial tears and complete tears. T1 signal, it kind of increases in high grade. PD-FATSAT signal increases in high grade. You get more heterogeneity in the signal as the grade goes higher. But what's been shown to correlate clinically is none of these findings really are very helpful clinically. Other things to look for are perineural fibrosis, architectural distortion of the nerve itself, if you can get high enough resolution, if the nerve is large enough. If you get a bulbous enlargement at the end of the nerve, that's significant, which is basically what Morton's neuromas are. And if you get complete discontinuity, obviously that's important. And then if you get associated denervation changes of the skeletal muscle and the distribution of the nerve, that's obviously significant. And these 5 things tend to correlate with clinical problems and tend to be associated with change in management of the tendon of the nerve. I think I have another lecture elsewhere where we go into this in greater detail. But these are the 5 things you really look for to mostly determine the clinical significance. If you get discontinuity, that's usually a surgical condition. And there are a bunch of different surgeries that we'll talk about in another lecture concerning that. And perineural fibrosis and architectural distortion tend to be associated with neuropathies and clinical symptoms. So let's look at the ulnar nerve. It's contained, as you all know, in the cubital tunnel. The floor of the cubital tunnel is the medial capsule and the ulnar collateral ligament. The roof is the retinaculum, the flexor carpio-ulnaris aponeurosis. Now, looking at the cubital tunnel, the retinaculum, there is a grading system for it. Type 0, it's absent. And if it's absent, it means it's not there to help contain the nerve in the cubital tunnel. So you can get medial dislocation of the nerve, and this is associated with frictional neuritis. So in a case like that, which I'll show in a minute, you try to look at the fluid-sensitive images and see if you see swelling and edema within the nerve, which can be associated with frictional neuritis. Type 1A is normal. It's thin. It's taut and full flexion. It can be a little bit thickened when you go into flexion, but we usually image the patients in taut and full flexion. When we image patients, it may not seem completely taut, but we'll show examples of what normal looks like. Type 1B is thickened, and it gets taut short of full flexion, so patients may start getting some symptoms if they fully flex the elbow. And this is thought to produce a dynamic compression of the nerve and can lead to ulnar neuropathies. And then the type 2 is replacement of the of the retinaculum by the anconeus epitrochlearis muscle, and this is thought to produce more of a static ulnar compression. So let's see. Elior. It's a 35-year-old Major League Baseball relief pitcher with medial elbow pain.
Right, so looking at the cubital tunnel, looks like there's this superficial thickening there. Yeah, is that the ulnar nerve that's
Okay,
subluxed?
yeah,
Or?
and then obviously if we have images prior, superior and inferior, if you go more proximal, you'll see that this will be a linear structure that'll end up in the muscle here. If you go more distally, it's also, you can follow this all the way down into the distal muscles. And so this is, if we had all the images, you would see that this is the ulnar nerve. It's medially displaced. We don't really see a retinaculum around it. And this is a type 0 retinaculum with instability. It's a larger cross-sectional area than it normally should be. And this patient had clinical findings of an ulnar neuritis due to instability and frictional injury to the nerve.
All right, so looks like there's some irregularity to the retinaculum, and the ulnar nerve is enlarged and increased in
See a good
signal.
retinaculum here. Maybe you can see something there. But it is swollen and edematous, and this was another patient who did not have a well-developed retinaculum, and they could feel displacement of the nerve when they flexed and extended the elbow on clinical examination. So this was thought to be ulnar neuritis from also a type 0 anatomy. Okay.
So we have a 42-year-old with 6 months posterior medial pain. The ulnar nerve looks like it's subluxed and doesn't look swollen. Maybe a little edematous on the sagittal.
I can see where it hurts. You go to the sagittal, right? There's a little bit of probably edema within it. And this was another type 0.
Mhm.
Okay, looking at the cubital tunnel on the axial on the left, there's looks like there's two structures there.
Here and here.
Yes. I think the ulnar nerve is the more lateral
Or more medial.
or more medial, yes.
Yeah. So this is the ulnar nerve. This is probably a little fluid in the joint space there.
Okay.
So that's fine. And then we see this structure next to it, right there. And remember, we're an extension, and the flexor retinaculum is generally not taught in extension. So this is the normal flexor retinaculum, 1A type morphology. And if we go to the sagittal image, well, it's nice uniform signal intensity within the nerve on the PD fat set, so there's really no edema. So this is normal.
All right. I guess that we're pointing to the more proximal course of the ulnar nerve. And
Right,
there's
so-
I
so
guess
if I-
there's a thin little band over it, right? Or
Yeah, well, yeah. So if I'm concerned about the ulnar nerve, I like to always start proximally and follow it distally,
Okay.
all beyond the elbow. So here we are proximally, where we see it in the medial aspect of the triceps. Now we're down at the level of the cubital tunnel.
all right. Well, the retinaculum looks very bowed, and the ulnar nerve is enlarged.
Yeah, so we see a nice thin retinaculum, but the ulnar nerve is definitely enlarged. It's a T2 weighted image, not a fat satted image. And we can see there is a little bit of increased signal intensity within it. If we go a little farther down, we can see further. Obviously, the PD or the T2 fat sat images would be better images for looking at edema. If we go we have a coronal stir sequence in this particular case. And this is that ulnar nerve, and right through the cubital tunnel, we can see it's a little bit thickened, more so than it is proximally or distally, and it's edematous in that area. And this was a patient who had clinical ulnar neuritis.
Let's see. So looking at the elbow again, the retinaculum looks a little thick. Ulnar nerve, I think, looks yeah.
The ulnar nerve there.
Mm-hmm.
There we can see the ulnar nerve on those two lines. Okay. So there we go.
Mm-hmm.
And then this is a bit thickened. It's uniformly thickened.
Mm-hmm.
This was thought to be a 1B. Most of the time, if you have a clinically significant 1B, you'll get more of a lumpy, bumpy thickening of that retinaculum with compression of the nerve. And this is more like what we typically see in the symptomatic ones, where even in extension it looks taut, and it's kind of not uniformly thickened, but very thickened down here, and there may be a little bit of edema within the nerve on the T2 weighted images. And that was a type 1B, thought to place that dynamic compression of the ulnar nerve. And a lot of people, there are some people who really like to use ultrasound. And I think that if you're ultrasound aficionado and do a lot of these, it can be a very good technique. We tend not to do that. Most people in the US tend to use MR rather than ultrasound, predominantly because MR is cheaper. And why is MR is cheaper? Because it doesn't require having a radiologist perform the procedure. And it's more reproducible. And if you have the images, most people are very comfortable looking at MR images, but most people aren't comfortable looking at somebody else's ultrasound images. So this is actually in Australia, where people use a lot of ultrasound, and I think it can be a good technique, but not one that we use here. And so he felt that this was also type 1B with compression and flexion.
Okay, so here over the cubital tunnel, it looks like an accessory menconius.
Okay, good. So there we can see the thickened accessory menconius. There's the ulnar nerve, which appears a little bit thinned in the area of the cubital tunnel. And this is a type 2, thought to produce a compression of the ulnar nerve from the pressure from the overlying muscle. I must say there are a couple of people I know who have had this and had ulnar symptoms, who've had the anconeus epitrochlearis surgically removed. And in the two cases that I know, neither of them really had any significant relief. But I haven't really looked at any large studies to know how common that is. I just know two anecdotal cases. One of which was my best friend's daughter.
All right. So here we also have an accessory anconeus muscle. The ulnar nerve looks a little flattened and increase in signal within the cubital tunnel.
So we typically don't use PD fat sats in the axial plane. If you know that there's ulnar neuritis, then I think you really need a PD fat sat in the axial plane. So if you know that's what you're going to do the study for, That's not a common complaint that we do an MR scan for, so we don't routinely use it. And for looking at a lot of other structures, we generally like the T2 non-fat suppressed in the axial plane. But if you know that the patient is being evaluated for possible ulnar neuritis, I would either add it or replace the T2 with the PD fat set. Okay. And then here we can see another type 2, or the anconeus epitrochlearis muscle with some edema within the ulnar nerve there. And here we can see edema within the ulnar nerve, which is localized right to the area of the cubital tunnel, normal distally. And if we had the next cut over, we could see it normal more proximally. And there's the muscle right here. And here we can see the anconeus epitrochlearis and the thinning of the nerve right in through here versus what it looks like proximally.
All right, so we have a 40-year-old with elbow pain for 2 years and wrist weakness. Looking at the ulnar nerve, it looks thick and edematous.
Okay, so this is a little bit, these are stir axial images from kind of a midfield scanner. This is actually the ulnar nerve here. This, as we'll see in a minute, is actually an edematous osteophyte with the ulnar nerve draped over it. And if we go to there's that osteophyte on the T1 weighted images. And here we can see this a huge osteophyte coming around here in a person with degenerative disease. And this was, and then if we go distally, what does the ulnar nerve innervate? Well, it innervates the extensor muscles. And here we can see some denervation changes here within the extensor muscles distally here. That's the flexor digitorum profundus in that particular area. So this is a patient who had cubital tunnel syndrome due to an osteophyte compressing the ulnar nerve. John?
You mean flexor muscle?
Flexor. Thank you. Thank you. Yeah, big difference. Thank you very much, John. Yeah, we're on the medial side. Thank you. Okay, so this comes to cubital tunnel syndrome. And so the flexor carpi ulnaris and the digitorum profundus muscles are innervated by the ulnar nerve, and you look for edema within them if you have cubital tunnel syndrome and compression of the ulnar nerve. And then there we can see the distal ulnar nerve where the arrow is. It's come from an article in Radiographics.
So that's a hourglass appearance, probably.
Right.
And have they determined whether the hourglass that develops because of the venous or blood flow, or is just the nerves edema?
I think it's nerve edema, John.
I would think so too, because but the vessels must play a role, especially the veins. But a lot of pressure is used in that area, so I don't know. I never read about any studies done on that subject.
Maybe some of the neuritis is due to decreased vascularity from the pressure. I don't know.
Uh, Maybe if I have time, I'll check it out, see if I can find this.
Thank you. Yeah, why don't you report back to us if you can.
Or you can have one of the fellows do that.
All right. Anybody volunteer?
That's even better.
I think Tayson just volunteered. Good idea, John. We used to give assignments all the time. We haven't done that this year. Okay, Elior.
Okay, so here, looking at the posterior elbow, I think that's an enlarged ulnar nerve.
Okay.
Yeah, there's some edema on the stir
Yeah.
sequence.
Yeah, good. And here are some axial images.
Um, yeah, the retinaculum looks intact. Looks like
Yeah,
there's
there's
edema
there
around it.
may be a little bit of scarring. So there's some speculated low signal around that.
Mm.
And we can see that there's a little bit of mass effect, and this whole area looks a little bit odd. Uh, and this turned out to be an ulnar nerve hematoma.
Right. Um, I see it on there. There is definitely effacement of fat within the cubital tunnel on the T1.
Yeah, and if you look, here's a sub-Q fat, losing that fat signal along here. You kind of blow it up, that's what it looks like.
So, yeah. Are we seeing those fascicles like on FOSS? I mean, in like a longitudinal plane there?
This turns out if you followed it up and down,
Mm-hmm.
this is the ulnar nerve here.
Okay.
So what's happening in through here?
Some sort of,
That this patient had previous trauma in this
Yeah.
location, and that's scar tissue. Here's another view of it here where we can see the scar in the soft tissues, and this was from external trauma, and this was post-traumatic scar, which then produced kind of focal atrophy of the nerve. I don't know from a direct compression of the nerve and injury or whether it was a vascular insult or something, and this patient developed ulnar neuropathy, and as all we could see was the scarring here in the area where the trauma occurred.
All right. Let's see.
So let's just start approximately. There's the ulnar nerve,
Mhm.
and then we can follow it distally
Yeah.
here. Then it goes over there, and then it's kind of lost in here. But put a circle around where it is. That's the ulnar nerve if you follow it down from
Okay.
cut to cut.
It's not where it's supposed to be. It's not in the cubital tunnel.
Okay, good. And we can see what looks like maybe a little scarring around it here. So this is ulnar nerve relocation. So this was surgery. If you remember the first Tommy John procedure, Tommy John actually developed ulnar neuropathy. They then went in because of that, and they moved the ulnar nerve from the cubital tunnel anterior to the condyle. And then his ulnar neuropathy resolved, and he was able to then pitch actually longer after he had Tommy John than before.
Well, they had Stark, a hand surgeon. I think he probably did most of the procedure.
Mm-hmm.
And I think nowadays, like I mentioned before, I think that's where hand surgeons work nowadays.
Yep. So this is a surgical relocation of the nerve. So this is the typical treatment for ulnar neuropathy, thinking that you're going to take whatever pressure you have on the nerve off by putting it into an area where it's not going to be caught in when you flex the elbow into some sort of a stretching position.
It's a difficult nerve to work with, even if you transpose it anterior or intramuscularly. Um, the results are never all that great as you would like. So it's a nerve that's very difficult to work with.
Yeah. And so that's why people have gone to great length to change the surgical techniques uh, for the Tommy John procedure to eliminate needing to move the nerve.
Exactly. I don't know how well you can pitch after transposition. That's but haven't treated many pictures, so I wouldn't be able to. You've seen a lot more pictures than I have, John.
Oh, yeah. Well, for many years after Tommy John himself, the standard was to always relocate the ulnar nerve. Uh, and a lot of those people went back and did pitching and became a very popular procedure. But there was I think, a relatively low, but still a real incidence of ulnar neuropathy in those patients. Um, but now it's reserved only to people who have ulnar neuropathy. I don't think anybody relocates the nerve now if the patient doesn't have symptoms.
Campbell's doesn't mention Tommy John anymore, which is kind of interesting.
Even the whole surgery?
No, it mentions a surgery, but doesn't mention his name.
Oh, really? Interesting. What do they
Maybe
call
he
it?
didn't. Maybe he didn't like the fact that his name was used. I don't know, but it's not in Campbell's anymore.
Really? Do they call
The
it the
last,
Job?
the,
They
the
call it the
last
Job
one.
technique?
I'm sorry. The last edition, they mentioned his name, but not in the last. Not on this last one
Well, what?
that I gave you the tape of, not the tape, but CD.
Yeah. How do they name the procedure?
They just call it um, Job procedure.
Oh, really? Interesting. Aha. So that they want the surgeon to get the name, not the patient. Okay.
Job probably was just watching.
Okay. Who's next?
Like so.
Okay. Looking along the medial epicondyle, there's linear increased signal. Could that be the ulnar nerve?
Okay, so this is a low field study, P1 and a stir technique. And then, but this is, excuse me, this really isn't posterior, so this really isn't in the region of the cubital tunnel. But you're right, this is a post-transposition where the nerve is more anteriorly located.
Okay.
And we can see there's a little bit
And
of edema within the nerve.
not positioned in a very good place.
Yeah. By the way, in that study that we did where we looked at 189 adults, asymptomatic adults, elbow, what we found is that you could see kind of a subtle amount of edema in a lot of asymptomatic elbows, but this kind of severe bright signal that we see here, we did not see in asymptomatic elbows.
All right, so we do have some scar on that.
Okay, so start up a high. Here's
Yeah.
the ulnar nerve. It then ends up over here, and
Yeah.
there,
Again,
and then here. And then here we can see, as you said, a lot of the spiculated low signal intensity characteristic of scar. And this is someone who also had a transposition of the ulnar nerve.
yeah.
And then see scarring in the cubital tunnel.
All right. So it says post-op ×2. That's thickening of the ulnar nerve there. Yeah.
So this, if you follow it up and down, this is the ulnar nerve. It's thickened, and we have this dense fibrosis surrounding the nerve. We go to the axial images. Here you can see that dense fibrosis. And this patient had very severe symptoms of ulnar neuropathy. So some people are just big scar formers, and if you get scar here, the scar develops and then it retracts, and then it starts tweaking the nerve and can be a real problem. So consequently, a lot of people really try to not have to translocate the ulnar nerve. We then go to the median nerve. It comes down by the supracondylar process. And actually, well, if you have a supracondylar process, then the ulnar nerve tends to go between that and the ligament of Struthers, where it can be compressed if people have a supracondylar process. We saw one of those, I think, last lecture. They're pretty uncommon, though. You can then come down to it goes through the pronator muscle here, deep to the pronator muscle, where it can also be compressed in a syndrome called the pronator syndrome. Then it becomes the anterior interosseus nerve, and it's compressed a little distal to the pronator syndrome, and then it comes down into the carpal tunnel, and if it gets compressed down here, then it's called the carpal tunnel syndrome. So this nerve can be an active nerve for us. So the supracondylar process, as we saw, is a congenital anomaly in humans. I think it's common in birds. It's associated with the ligament of Struthers, diagnosed by plain films, obviously. And then you get symptoms when you get compression of the median nerve here. Basically, you can have symptoms from that level distally, so you get symptoms throughout the forearm and the distribution of the medial nerve. So here's what the supracondylar process looks like. Ligament of Struthers here. The nerve and associated vessels go right through here, and this can put pressure on the nerve. And then here, this is actually that process right here. These are the vessels of the nerve coming down. You can see how they can be kinked and potentially injure the nerve and the vessels at the level of the supracondylar process. So if we go to the axial images, here's that supracondylar process, and here's the nerve and vessels in through here. So they can be compressed, and then that will then produce symptoms distal to that level. Okay. Let's see. Elderly female with median nerve palsy 1 month after a coronary angiogram.
Okay, so here we see an ultrasound. See an brachial artery is labeled, and the structure passing over it is that the median nerve.
Yeah.
Okay.
And, oops. So here's what the Doppler looked like.
Right, so there's lots of Doppler signal in this hypoechoic structure. It could be a pseudoaneurysm after procedure.
Yep, that's what it was. And that then compressed the median nerve at the level of the pseudoaneurysm. Okay. Then if you go more distally, you get the pronator syndrome, where the nerve goes through the pronator muscle or deep to the pronator muscle. You get nerve entrapment, and you can then get pain and numbness in the forearm with edema, the pronator teres. So this is kind of what it looks like. You get a lot of diffuse edema in this area due to the compression of that nerve.
All right, so I guess that high signal structure is our median nerve deep to the muscle there.
Yeah, so this patient had elbow, forearm, and wrist pain. So this is really from the elbow down. So that generally means that you're dealing with the lesion at the level of the elbow. And this patient also had dysfunction of the thumb and index finger, which is the muscles that some of the muscles that the median nerve innervates. So you've got to be worried about median nerve syndrome, it's relatively high. You don't have a supracondylar process, so the other highest lesion there would be in the area of the pronator. So this, and we can see that there's edema in the flexor digitorum superficialis, which is important for the index finger. And then what do we see here?
So we see edema in that flexor digitorum. I'm not sure. Is that
There's the flexor digitorum. There's a flexor digitorum superficialis. There's a flexor digitorum profundus. If we go distally, what do we see here?
See edema of those.
That's the
yeah,
pronator
pronator,
quadratus. There, edema and all of those.
So this is a denervation of the
And then
muscle.
see a lot of thenar atrophy here, and probably denervation, edema, and the thenar eminence, and that's typical of the pronator syndrome. So it's basically abnormal from the area of the pronator where the median nerve goes through the pronator, which is a superficialis and flexor digitorum muscles, and then distal to that, which gets the thenar area and the pronator. So that's a typical supus. And then there's the anterior interosseus nerve syndrome. It's really a compression of the median nerve somewhere between the pronator and the flexor retinaculum. This is usually due to direct trauma, and you get weakness of the thumb without numbness. And this is generally caused by trauma to the nerve anywhere along here. Actually, my first father-in-law worked in owned an oil company and worked in the oil business and had compression of his forearm as an accident in the oil fields, and slowly over time developed an ability to really use his thumb. This was like in the 1960s and 70s. This syndrome wasn't all that well recognized at that time. It took him years to find someone who diagnosed it. Then they went in and operated, took the scar off the nerve, and he got full function back in his hand. So it's not a common, but a significant. So in this case, the more proximal muscles tend to be pretty normal. What you start seeing is denervation of the more distal muscles. So the flexor digitorum superficialis and profundus are usually okay, but you get flexor pollicis and the more distal neuropathy, including the quadratus. So you differentiate these two basically is that if you have more proximal muscle involvement, then you're probably dealing with a pronator in that area. If the more proximal muscles are in good shape and it's only the more distal, then you have to think about something involving the nerve in between the two, which would and then here we can see going into the pollicis.
So do we not reliably find a median nerve within the forearm?
Yeah.
So we are basically looking for the denervation pattern to give us the.
Okay, so the question was, do we not see the median nerve well in the forearm, and therefore we're left primarily looking for the muscle changes? And I think the answer to that is yes, right now, with our current techniques. Now, if we start using some more sophisticated imaging of higher resolution using diffusion weighted or diffusion tensor imaging, I think that may well change. But in general practice, I think we still look primarily at the muscles. But over time, the problem is that diffusion tensor and a lot of those more sophisticated techniques require a lot of experience to learn to use them properly. These problems are pretty rare, so most radiologists Most imaging companies aren't going to pay for the technology to do it, because if they only do a couple a year and it costs hundreds of thousands of dollars, it's not worth it. And therefore, I think most radiologists at this point really haven't put the effort into actually learning the techniques.
There's a book on the fellow's cupboard there that by Spinner, trauma of the forearm, that talks about all the different nerves and procedures. That might be something that fellows, if they're interested, might take a look at it.
Okay, thank you.
It's a
Yeah,
very
yeah.
well done book for surgeons.
Is it one you gave us?
Yes.
Okay, thank you, Spinner. Good. Who's next?
So we have a 48-year-old with limited pronation, myalgia, and a positive Tinel's. Looks like there's edema in the muscle belly. Is that one of the flexor carpi radialis?
Okay, here.
Similar, some more edema there.
Okay. So this is from Dr. Su, and here we can see these are the muscles that the median nerve innervates, basically the anterior distal muscles of the forearm. And then there you can see where it comes down past this, where the pronator syndrome occurs, and then anything distal to that. And this area is going to be the anterior interosseus injuries. Again. I guess we'll cover the carpal tunnel syndrome in the wrist lectures. Okay, and let's go on to the radial nerve. And here, one of the common syndromes of that is the posterior interosseous nerve syndrome, also called the radial nerve syndrome, also called the supinator syndrome, and the radial tunnel syndrome, which we can see here. So the radial tunnel syndrome, you get compression or entrapment of the posterior interosseous nerve, typically the deep branch. You get pain in the lateral forearm, and MRI, we get denervation and atrophy of the supinator and extensor muscles. So I think the supinator muscle is the one to really look for in this particular syndrome. So it's also called the PEN syndrome, posterior interosseous nerve syndrome. You get motor weakness and inability to extend the fingers and extend the thumb. So the median nerve, it's flexion of the thumb and flexion of the second finger, so that touch the two together. With the radial nerve, we're dealing with the extensor muscles and extension of the fingers and thumb. And here we can see the radial nerve that comes down. We're anterior to the radial head, which goes over. And usually you can see it or its branches right around the radial head. And then it divides in this location. The posterior interosseous nerve now goes posteriorly and goes through the supinator muscle and innervates the supinator muscle in the area. This is the arcade of Frosch. Right in through here, which is a typical location where it can get compressed. And here's the ECRB out here, which we see, and then where distal, the anterior branch comes down anteriorly there. So with the radial tunnel syndrome, you'll tend to get pain here laterally, which we can see your lateral forearm. There are other branches from the radial nerve which go to the skin. The lateral antebrachial cutaneous nerve, you can get entrapped in this area as well, which produces typically skin symptoms laterally here. And this can be caused by biceps irritation in throwing athletes. So the radial tunnel syndrome often starts around the arcade of Frosch. Here, as you can see, there are a lot of nerves and vessels here. The posterior interosseous nerve goes down through here. This is the supinator muscle. Here's the anterior branch coming up through here. So this is the area that we're interested in. Let's see. Here we go.
Okay, 26-year-old male, right radial head pain, right thumb extension limitation. Looking at the supinator muscle, is there some atrophy that we're seeing?
Some abnormal signal there,
Yeah.
definitely. Here we can see is the see a little bit of edema here on the steraxial images. PD fast head images, we don't really see it quite as well. A little inhomogeneous signal intensity there. Clinically, this patient had radial tunnel syndrome, and we see it primarily on MR as abnormality to the supinator muscle. So the supinator muscle is kind of key in this diagnosis. And then the arcade of Frosch is right above the most proximal aspect of the supinator muscle because the pin dives deep to it. The superficial radial nerve stays anterior to it right here. Okay, so this is the arcade of Frosch, the very top part of the supinator. This is the posterior interosseous nerve here, the superficial radial nerve there, and then the posterior one will dive in through the supinator. Yeah.
When you're doing surgery on that radial head, you're close to that nerve, and it's always been something that worried me when I was at the elbow. Don't go too far.
Yeah.
Distally.
So I don't expect for you to remember this, but the radial tunnel syndrome actually refers to compression of the posterior interosseous nerve without motor deficits. So it's a pain syndrome. The posterior interosseous nerve syndrome or the PIN syndrome is actually a motor neuropathy. So no, I don't think that's something that radiologist necessarily needs to remember, unless you're dealing with a lot of physicians who work with nerves in this location, in which case you have to learn their nomenclature.
Well, sensation is important, especially in the radial nerve.
Yeah. So here we can so here we can actually supposedly there's atrophy on one side, and we can see the nerve. Yeah. So so anyway, this was a patient who had a lipoma, as we can see here, which actually compressed the nerve. There's the anterior nerve there. The posterior interosseous nerve is going to be over here, and you can follow them down. And we can see the nerve coming here, and this is over the lipoma. And you can see the nerve going over the lipoma there. And due to supinator lipoma. And I guess there's denervation changes of the extensor muscles. I had a little trouble seeing it on the regular syndrome, but this was a posterior interosseous nerve syndrome with pain. Okay, who's next? Okay.
So it looks like adjacent to the radial neck, I think anterior to it, we have a multilocular high signal structure, maybe a ganglion cyst.
Okay. And we see it here as well. T2 fat suppressed as well as the T1.
Then, yeah, with some fatty streaking within that supinator muscle
Right.
belly.
So this is radial, bicipital radial bursitis ganglion cyst, which compress the posterior interosseous nerve, producing the Penn syndrome. Okay.
All right. So we have a 5-year-old male. Looks like there's an effusion of the elbow and maybe a fracture of that ulnar. Or am I making that? There, yeah, I was kind of looking there.
Okay, that looks like it's right. Let's see a fracture here.
Yeah.
Okay. So
And
this is a
dislocation.
montague fracture.
Montega.
Let's see it here. And after they reduced it, he couldn't extend the fingers.
Mhm.
So they got an MR scan.
Yeah, so it looks like there's a lot of diffuse edema. I'm looking at the nerve. Let's keep
Following that along there. You can see that there's a lot of edema within the supinator muscle there. Coming down. And within other muscles.
Mhm.
In the old days, we used to wait for the muscle to return function. Nowadays, it's a lot easier.
And here's this an ultrasound also looking at that nerve going through there. And here we can see basically a hematoma or swelling. So this was posterior interosseous nerve entrapment with probably hemorrhage and swelling of the supinator muscle and edema distally.
It affects the thumb too.
Right. Extension. Okay, why don't we stop here and we'll pick up here tomorrow, okay?
Have a good evening.
Thank you, John.
Have a good one.
All right,
Take care.
thank you. Thanks, John.